A novel coronavirus outbreak was first documented in Wuhan, Hubei province, China, in December 2019. After that, life has never been the same again. So today, we will be talking about COVID-19 and COVID-19 vaccination in pregnancy. And the information on this lecture are from the Philippine Society for Microbiology and Infectious Diseases, Philippine COVID-19 Living Recommendations, and from the PIDSOG Handbook, a guidance for clinicians on the obstetric management of patients with coronavirus disease 2019, and the POGS Practice Bulletin on COVID-19 vaccination of pregnant and breastfeeding women. So we always have to have the right diagnosis in order to have the correct intervention. And for more than a year, we have been living with COVID, and everybody knows what are the signs and symptoms of COVID-19. But for the sake of discussion, we have to differentiate the case definitions for COVID-19 in pregnant women. So we may have the term suspected or suspect. We have a probable case and a confirmed case. A suspect case would be somebody with acute respiratory tract infection, or what we call influenza-like symptoms. And these may be patients or people who have close contact with a confirmed COVID-19 case or in absence of an alternative diagnosis. So there was a time when people would say that they just had fever. When they were brought to the hospital, it's COVID. When they were run over by a bus and brought to a hospital, it's COVID. And when somebody has appendicitis, brought to the hospital for surgery, then it's COVID. However, for public health, it's important that you consider anybody with symptoms of influenza-like illness like fever, cough, colds, flu, or sore throat, or loss of sense of taste and smell, and diarrhea. These may be symptoms of COVID-19. So it's COVID-19 unless proven otherwise. Somebody who has a clinical presentation that is compatible with COVID-19 would probably be labeled as COVID probable. This is a suspect case who has an inconclusive or equivocal laboratory result. So we consider them as probable case, meaning we treat them as if they had COVID even if they have a negative result or the result proves inconclusive or equivocal. But somebody with an RT-PCR result of COVID-19 positive, meaning RNA was detected in the RT-PCR, then this would be labeled as a confirmed case. You may say COVID-19 positive, severe, laboratory confirmed. Okay, so we have to define what a close contact is. And a close contact is somebody with direct physical contact with a known or confirmed COVID-19 case for at least 15 minutes within 2-meter distance. So this may be a person living in the same household or having direct contact with a COVID-19 case, like shaking of hands. And this is the reason why we have the air hugs or the flying kisses instead of greeting with shaking of hands. Or a person with unprotected direct contact with infectious secretions of COVID-19 case, or having face-to-face contact within 2 meters more than 15 minutes, or in a closed environment, and a healthcare worker or person providing direct contact or care for a COVID-19 case, or a laboratory worker handling specimens from COVID-19 case without personal protective equipment. These are examples of close contact. And this is important for case finding or contact tracing and for the health declaration forms that we fill out wherever we go. However, you may see that the Delta variant spreads more easily than previous variants. So it may cause more than twice as many infections. It's spreads faster than the usual variants, and it causes more severe illness than the previous variants, and unvaccinated people remain the greatest concern because they have a more severe illness or even the risk of death. Patients who are fully vaccinated may still have breakthrough infections with COVID-19. However, it is the time that it takes for them to transmit the virus to other people is shorter, meaning that they are infectious to other people on a shorter period of time compared to those who are unvaccinated. So this is the problem with the Delta variant. If you see here, this is the cumulative distribution of our cases in Central Visayas, in our hospital, in Vicente Soto Memorial Medical Center. You compare the first surge around April or May, and then the second surge, which was in January, up to May. So the second surge is far higher in peak compared to the first surge. However, if you look at the third surge, the time period wherein you have high number of patients with severe and critical cases is longer. And this shows the heavy burden of COVID-19 on the healthcare system. So we don't want a third surge. And it's important that we look at the long-term developments on how we can prepare airway sewage so that we do not transmit COVID-19 and we do not have a third surge of COVID-19. So looking at the diagnosis again, so these are the common clinical features of COVID-19. I'm sure everybody knows this by heart. If you have fever, cough, shortness of breath, muscle aches, confusion, headache, sore throat, rhinorrhea, chest pain, diarrhea, nausea and vomiting, and fatigue, and also loss of sense of smell and sense of taste. So should asymptomatic pregnant women be screened for SARS-CoV-2 prior to delivery? Yes. So pregnant patients should be considered for testing, and this should be with the gold standard of RT-PCR at 37 to 38 weeks to give time for the release of the results prior to delivery. So asymptomatic pregnant patients can be COVID positive and can transmit COVID to their partners, to their patients, to their families, and even to healthcare workers. So it's important to test pregnant patients even if they're asymptomatic because they may also transmit COVID-19 to their unborn child. Okay, so what is the gold standard? You have to test with RT-PCR or reverse transcription polymerase chain reaction. This is the gold standard for testing COVID-19. The reason why we want to diagnose pregnant patients is to tailor frequency and location of prenatal care to lower the risks to both the mother and their partners and their families, and to decrease the risk of transmission to other patients, healthcare personnel, and the family living in the same space. And we also have to plan for labor and delivery. By now, we probably have a clean labor room versus a contaminated or infectious labor room or a septic labor room. So we can divide or have an algorithm how to separate for engineering infection control patients who are positive for the RT-PCR or have COVID or are suspect and probable from those who are tested negative RT-PCR. And we have to plan for mother-infant separation strategies if necessary because we don't want the baby to get COVID-19 as well. So what is the role of antibody testing in the diagnosis and management of COVID-19? So they may be used as an adjunct to RT-PCR but must not used as a standalone test. So it's the RT-PCR that we use to diagnose COVID-19. However, when a patient has already been isolated, the antibody test may guide when to diagnose the patient as having been recovered. But the latest guidelines is now time-based rather than test-based. So before, we would not allow a patient to go home from isolation unless they test RT-PCR negative. However, it has been found that the RT-PCR may remain positive up to 90 days. So, when you want to determine non-infectiousness of a patient who tested positive for RT-PCR, we no longer use the RT-PCR as a test. We may use the antibody test to help us determine whether they are still infectious or not. However, based on the DOH guidelines, we now use 10 days of isolation for asymptomatic and mild cases and 21 days for patients with severe and critical COVID-19, regardless of testing. But if you look at the antibody test, okay, you look at the blue line, and that is the SARS-CoV-2 RNA and antigen. So if you look at testing on day 5, for example, a symptomatic stage, you may test a positive RT-PCR or antigen, but the antibodies start to develop at day 7 and increase. The IgM becomes detectable, however, it decreases and disappears by day 21. However, if you have IgG antibody already, this usually comes out on day 14 and increases and remains in the blood and provides long-term immunity. Therefore, if you are using a rapid antibody test, if you have a negative symptom, negative IgM, and negative IgG, then you have to adhere to quarantine protocols implemented in the area. It's either you don't have RT-PCR, you don't have COVID-19, and you just have to isolate, okay? If you don't have symptoms but IgM is positive and IgG is negative, assuming you have an RT-PCR positive, you have to isolate for 14 days, then repeat. If you're a healthcare worker, then you have to swab for RT-PCR. Now, if the IgM is positive and the IgG is positive, considered recovered, no RT-PCR testing needed, as well as if the IgM is negative and the IgG is positive, no RT-PCR testing needed. So, if there are symptoms, you have to isolate and swab for diagnosis. So this may be the clinical significance of your IgM and IgG serology, but I would not recommend the pregnant patients to test with this test routinely because, again, it is not a standalone test. We still utilize the gold standard, which is your RT-PCR test. For the chest X-ray and the chest CT and lung ultrasound, it's not recommended as a screening tool in asymptomatic to mild cases, but the most common features include lobar, multilobar, and bilateral lung consolidation. If you look at patients who have indicated moderate to severe features, then you may consider doing your your X-ray and CT scan. But for patients with COVID-19 and evidence of worsening respiratory status or progressing symptoms, then you may consider doing your imaging, your X-ray and CT scan. Okay? If you look at your CT scan, this is how you will see or think of COVID-19 when you have beautiful ground glass opacities on the CT scan. Whereas when you look at going back to your diagnostics, now we have come up with the rapid antigen test kits. I'm sure a number of hospitals utilize this for screening. The RITM has evaluated 13 brands of antigen test kits that may be acceptable, and the World Health Organization recommends a minimum of sensitivity of 80% and specificity of 97%. So even RITM accepts a sensitivity of 80% and a specificity of 97% for you to consider using rapid antigen test for your screening and diagnosis. And lately, DOH has started to document these positive cases using the rapid antigen tests. So we look at the effect of pregnancy on COVID-19. So do you think that pregnant patients are at higher risks of getting COVID-19? Well, the answer is no. Pregnant patients are at the same risk of transmitting or getting infected with COVID-19. Pregnant women do not have or do not appear to have an increased risk of acquiring COVID-19 infection. However, there's a big but. The effect of COVID-19 on pregnancy suggests that individuals admitted to hospitals with COVID-19 are hypercoagulable. And considering that pregnancy is also known to be hypercoagulable state, then they have higher risk of maternal venous thromboembolism. And also, there are a lot of known obstetric complications like preterm delivery, PPROM, intrauterine fetal demise, or distress from COVID-19 maternal infection. Now, this is probably because of the hypoxemia. And we know the phenomena of the happy hypoxics, meaning I am talking to you, I can converse, I don't feel bad, but when I check my oxygen saturation, I'm actually hypoxic and I don't even know that I'm COVID positive. So that's a condition called happy hypoxics. That's why patients with COVID-19 have to be monitored closely, whether at home or at BICs or TTMFs or in the hospital. And it has been shown that cesarean section rates are vastly higher than in the general population, possibly indicating iatrogenic reasons. So can COVID have an effect on fetus in utero, or can the fetus in the womb acquire COVID-19? So there is no clear evidence for vertical transmission from mother to fetus, but limited cases have shown no evidence of vertical transmission in patients during the last trimester of pregnancy. So how do we manage pregnant patients with COVID? So should corticosteroids be given? Yes. If the patient is preterm, okay, 24 to 33 weeks age of gestation with suspected or confirmed COVID-19 who are at risk of preterm labor within 7 days may benefit from antenatal corticosteroids, and we give the same dose as before. So when is the best time to deliver? It depends. It has to be individualized based on your patient's case scenario. If the women can be treated, pregnancy should be allowed to continue until term. But that needs fortitude on the part of the obstetrician. But if a pregnant woman is critically ill, her clinical deterioration may lead to intrauterine fetal demise or loss of both mother and infant. So we have to continue and strengthen fetal and antenatal surveillance. Okay, so because we do not know at any point of time, you may have to deliver the pregnancy. So the indications for early delivery depend on the mother's clinical status, gestational age, and fetal well-being. And these would be the indications for delivery with severe COVID-19 infections. So you would still have your maternal indications and your fetal indications. So should induction of labor be instituted? So it also depends if the patient's findings are conducive for induction of labor. However, there may be increased exposure of the healthcare workers to a COVID positive pregnant woman. So the mode of delivery would still depend on standard obstetric indications because COVID-19 is not an indication to change the route of delivery. So vaginal deliveries can be attempted and cesarean section is performed if you have standard obstetric indications or fetal indications. As far as anesthesia given to pregnant women is concerned, so neuraxial anesthesia, either epidural, spinal, or caudal is preferred because intubation and extubation during general anesthesia are considered aerosol generating procedures which may contribute to the spread of the virus as droplets and should therefore be avoided in COVID-19 pregnant patients. So in the Philippine General Hospital and adapted in our own hospital, when we have patients for general anesthesia, it's the anesthesia team that comes first to do the procedure because it's an aerosol generating procedure. And then we allow the rest of the surgical team to come in after a few minutes, like almost up to 30 minutes, to allow or the risk of transmission to be lower. So can we do EINC? I'm sure we are all advocates of essential intrapartum and newborn care. We have seen the evidence that this has benefits to both the baby and the mother. So considering that the baby can get COVID-19 from a COVID-19 positive mother, the mother should be advised to strictly follow proper hand hygiene, cough etiquette, wearing of a tightly sealed mask, and disinfection of surfaces before the baby can be allowed to have EINC. Okay, so the mothers can breastfeed if it is their decision. So if the decision to breastfeed depends on the patient and their family, because you have to consider that the ways that we can minimize transmission of COVID-19 to the infant or to the baby. So the mother has to be separated from the baby except when breastfeeding. So you have to have 1:1 caregiver for the baby while the mother is not breastfeeding. The mother wears a well-fitting medical mask at all times when when near her baby or other household members. She practices hand washing with soap and water prior to touching her baby, and she follows cough etiquette. And the baby is not exposed to the sick mother's respiratory and stool secretions. So yes, patients with COVID-19 may breastfeed their baby, but they have to make that decision and take the risks. So these are the severity classification of pregnant women and the recommended management. They're all in the PIDSOG Handbook. So patients with stable comorbid illness and mild pneumonia, you may perform RT-PCR for diagnosis as well as chest X-ray and laboratory tests, and manage the patient as CAP low risk. If the patient has severe acute respiratory infection, presents with fever, respiratory rate more than 30 breaths per minute, or severe respiratory distress of O2 saturations less than 92, then this is the battery of diagnostic tests that we recommend that you have as baseline, and the patient must be admitted and must be co-managed with the internal medicine as CAP moderate risk. So it's important that we know how to manage patients with severe acute respiratory illness. However, when the patient becomes critical, then you have to manage the patient as CAP high risk. And for patients like this with maternal hypoxia or hypoxemia, you have to make sure that you monitor the baby closely, because at any time, you may have indications to deliver. So pregnant patients with acute respiratory distress syndrome or worsening of or progression of the disease, then you manage based on ARDS. So when we're talking about infection control for COVID-19 in pregnancy, this is mainly for the safety of the healthcare workers and the patient. In our hospital, we identified red, yellow, and green zones. Green zones are safe areas where patients are COVID negative. Yellow zones are for patients awaiting their results, and red zones are where we admit patients who are confirmed COVID positive. So you see that our OBGYN, our perinatal building, labor room, delivery room, and wards is considered yellow. And we also have patients who come in with negative RT-PCR. They are admitted in the green zone. So our triage is to ask or check if there is a history of fever or respiratory symptoms, history of exposure or contact with COVID-19, or we used to have these hotspot barangays or geographic origin from an area with an increased number or sustained local transmission. We used to define this as more than 5, but now we realize that COVID is everywhere. And at the time of the first wave, we divided our team to COVID-19 team and non-COVID team. However, as the number of cases increased, we realized we cannot keep up with the two teams, and we merged them into one team, and it was the patients that we segregated according to COVID negative or COVID positive or awaiting results. And we made sure that even in our wards or in our labor room, we had identified the red, yellow, and green zones. Excuse me. So this is how our admitting section looks like. And this is our OR. So we had 2 emergency CS ORs. And when we deliver patients, we wear the full PPEs for our own protection. So as far as COVID-19 vaccination is concerned, so we have to give this information to pregnant patients about COVID-19 vaccination. So the risks of COVID-19 in pregnancy, which includes higher risk or rates of pregnancy-induced hypertension, preeclampsia or eclampsia, infections requiring antibiotics, greater risk of ICU admission, longer hospital stay, increased cesarean delivery rates, and premature births. The benefits of vaccination, on the other hand, in the local epidemiologic context, if there's an increased number of COVID-19 in the community, or if there's another surge, then the benefit of vaccination increases. And you also have the current limitations of safety data because pregnant women are always excluded in the randomized controlled trials for vaccines. And the COVID-19 vaccine does not cause COVID-19 disease. I've heard it asked me several times, Doc, is the reason why my RT-PCR positive is because I just had my COVID-19 vaccine? No, it means that you have COVID-19 infection. So COVID-19 vaccination does not cause COVID-19. So COVID-19 vaccination is recommended to all pregnant and breastfeeding mothers or women. It is safe in the first trimester of pregnancy. There are no known maternal or fetal effects, and no pregnancy test is required. No, when you get vaccinated, you will not be asked of a pregnancy test because even pregnant patients, no, it's safe to get vaccinated. And approved for use, you have Pfizer, Moderna, Sinovac, AstraZeneca, J&J, and Gamaleya. So any type of or brand of vaccine is safe for pregnant and lactating women. Okay. So please encourage your patients to get vaccinated. So you can also give vaccines to lactating women because it prevents or protects the pregnant and lactating women against severe and critical COVID-19 infection. Because COVID-19 infection in pregnancy has the risks of all of these for both the mother and the baby. Okay, so preferably the vaccine is given from 14 weeks age of gestation, just like all other vaccines, but you may give the vaccine at any age of gestation. So that's for my lecture. I hope that we have been adequately discussed the beginning and a little bit of history of COVID-19 and how to diagnose COVID-19 using your RT-PCR or the value or role of your chest X-ray and CT scan, as well as your rapid antibody test and your rapid antigen test. And also the management or effect of COVID-19 on pregnancy, and the effect of pregnancy on COVID-19, as well as some of the management issues for pregnant patients, including essential intrapartum and newborn care, and recommending vaccination, any type, any brand of vaccine for your pregnant and lactating mother, so that they may also have that added protection against COVID-19 as we continue to live with COVID-19 in this pandemic and onwards. And hopefully we can develop our communities, our engineering infection prevention control measures so that we can live safely with COVID-19 in the future. So as we continue managing pregnant patients, I hope that we will not allow our fear to paralyze us and make sure that we advise our pregnant patients to get tested and to get vaccinated. Thank you and stay safe.